السلام عليكم، مساء الخير. أنا أحمد الأمير، نيورو أوفثالمولوجيست وأنتيو سيجمنت كونسلتنت في مستشفى الملك عبد الله الجامعي جامعة الأميرة نورة. Welcome everyone to this subspecialty lecture. I know neuro ophthalmology is rare subspecialty and it's difficult to get training, especially في بعض البروجرامز اللي ما عندهم neuro ophthalmologist. فأعتقد إنه الآن أغلب البروجرامز في neuro ophthalmologist وفيه formal neuro ophthalmology training, which is good. الحمد لله. I don't like the word papilledema, so we named the lecture as disc swelling. طيب. True versus pseudo, because papilledema is one differential of disc swelling. Okay, so let's make it broad and we call it disc swelling. Okay. طيب, can you describe? Can anyone describe? نخليها شوية interactive عشان تصحصحون معانا. Can anyone describe? طيب, قلت لكم أنا لا تقولون بابليديما. تمام. I told you. أنا كنت أنتظر بس تقولين بابليديما. It's okay, no problem. يعني it's lecture interactive. يعني anyone can say anything even if it's wrong. I know it's commonly described as papilledema, bilateral disc swelling, but bilateral disc swelling, if we want to call it papilledema, it has to be bilateral disc swelling secondary to high intracranial pressure. But is this one secondary to high intracranial pressure? We don't know. We don't know the full picture. We don't know the history. We don't know the examination. We need to have full picture in order to call it papilledema. By this picture, we can say bilateral disc swelling. Is this true ولا pseudo? في حد عنده اعتراض أنه ما هي true؟ في حد يقول pseudo؟ في حد شاك pseudo versus true؟ طيب. أولا هنا it's blurred margin. The vessels here are obscured. There is flame-shaped hemorrhage. There is no question this is pseudo. This is true disc swelling. So we call it bilateral disc swelling, okay? True disc swelling results from the impaired exoplasmic flow, and the signs that suggest true disc swellings are elevated disc with blurred margin, peripapillary RNFL اللي هو retinal nerve fiber layer opacification obscuring the blood vessels, hyperemia with dilation of the optic nerve head surface capillary net, absent spontaneous venous pulsation. However, it can be absent in normal patients. If the cup is still there, if you see no cupping or anomalous disc, small crowded disc, this can be pseudo-papilledema. But if there is cup and blurred margin, it's likely to be true disc swelling. And if you see peripapillary hemorrhages, exudates, cotton wall spots, this indicates true disc swelling. Any question here? Clear? Okay. So, we said disc swelling. What are the differentials? I don't like to call it papilledema, so let's make it disc swelling, okay? Can be pseudo, but in our example, it's true disc swelling because of the signs we discussed. Papilledema, which is secondary to high intracranial pressure. Optic nerve diseases, you can name it. Optic neuritis, perineuritis can present with bilateral disc swelling. I have seen cases from Kekish ER labeled as papilledema, sent to neurology, done workup for papilledema, and they don't know the diagnosis. And it turned out to be optic neuritis, treated with IV steroid, vision returned to 20/20 1 week later. Okay, so bilateral disc swelling can be a sign of atypical optic neuritis. Compressive optic neuropathy, infiltrative, toxic, secondary to amiodarone. That's why you need to take full history and examination in order to differentiate. Ocular causes like CRVO can present with disc swelling. But when you check the retina and you do dilated fundus exam, you can see the tortuosity and dilation of the veins and the hemorrhages. Hypotony, uveitis. Systemic causes like severe hypertension, diabetic papillopathy, electrolyte disturbance from uremia or hypocalcemia can present with bilateral disc swelling. But it's mainly diagnosis of exclusion. I'm talking about severe hypertension and diabetic papillopathy. طيب, let's take any question. طيب, take picture of this differential. Very important. طيب. Keep it in your mind whenever you see a patient with disc swelling. 19-year-old woman complaining of headache for the last 1 month. Exam was 20/20 VA, color vision normal, pupil was normal, reactive, no ABD, no RABD, motility was full, and the dilated fundus exam showed bilateral disc swelling. You do visual field, which showed this finding. Can anyone describe this? A large blind spot. So what's the diagnosis here, or what's going on before diagnosis? What is this case? Is this optic neuritis? Is this CRVO? What is it? Bilateral disc swelling. Ish. Papilledema. Exactly. Patient, normal visual function, normal vision, normal color vision, bilateral disc swelling. Patient is having headache. Okay. So we can say papilledema. You work the patient up for papilledema. How to take the history? As in any case in medicine, you take the chief complaint, history of present illness, medication, past medical, surgical, and ocular history, social history, family, and systemic review. More specifically, you need to ask about symptoms of high intracranial pressure, headache, that is positional, increase with laying down or early morning headache, pulsatile tinnitus, which is whooshing sound, like hearing your heartbeats, like shh, shh. It's not ringing sound. So when you ask the patient, do you have tanin? No, tanin does not describe the pulsatile tinnitus. Pulsatile tinnitus is shh, shh, shh. Okay? Nausea, vomiting, transient visual obscuration lasting for seconds, like blackout, gray out, or white out of vision, lasting for only seconds. It's not like the blurred vision that is commonly seen in dry eye. The vision is blurred, then when I blink, it's clear. This is different. Double vision, from what? Why? Sixth nerve palsy. Why sixth nerve palsy? False localizing sign. ليش وش معنى false localizing sign؟ بالضبط هذه كنت ابغى اسمع الكلمة long course. Wrong. It's not long course. تمام؟ The longest nerve is the fourth nerve. Okay? But طبعا هذه half wrong لأنه the course of the sixth nerve palsy is the reason why you have false localizing sign. I will show you a photo of that explaining why the sixth nerve is commonly affected in high ICP or high intracranial pressure. Other neurological symptoms like numbness, weakness, trouble with the balance, past medical history of cancer, maybe there is metastasis, DVT, or pregnancy loss, indicating coagulopathy. لأنه venous sinus thrombosis can cause high intracranial pressure. Renal failure from uremia can cause bilateral disc swelling. Severe anemia can be one of the causes of high intracranial pressure and papilledema. Diabetes, endocrine disease, etc. Medications, ask about acne medication, isotretinoin, tetracycline, steroid withdrawal, cyclosporin, oral contraceptive pills, and lithium. Those are linked with increased intracranial pressure. For any patients with neuroophthalmic complaint, you need to do full history and examination, okay? Exam, don't just jump on the slit lamp and that's it. That's for cornea, cataract, retina. If you want to see retina detachment, just do fundus exam, retinal slit lamp examination, that's it. For neuroophthalmic examination, we don't diagnose based on findings. We need to have full picture in order to reach the correct diagnosis. If we see bilateral disc swelling, we don't know, is this optic neuritis or papilledema or something else? That's why we need to take full history and exam. Exam include the vision, visual field, color vision, pupil examination, cranial nerve exam, motility, including the saccades and pursuit eye movement. Look for nystagmus, and then you can do the slit lamp examination. We said VA is usually unaffected in patients with papilledema, صح? I received patients with papilledema with decreased VA labeled as posterior uveitis, okay? And the vision was 20/80. Could the vision be low in patients with papilledema? Yes. In what situation? Good. It's rare to have compressive lesion compressing the optic nerve and causing high intracranial pressure leading to papilledema in the other eye. And we call this Foster-Kennedy syndrome, okay? Other macular edema, exactly. This patient, this is true, all true patients, tamam? Papilledema with subretinal fluid going under the fovea, causing decreased vision. So there's subretinal fluid, tumor compressing the optic nerve, chronic untreated papilledema. Patient is having papilledema for few months or years untreated. The patient can have progressive vision loss. Or if the disc swelling is very severe, and we call it fulminant papilledema, severe disc swelling with rapid vision loss within 1 month. This is the definition of fulminant papilledema. But if you see grade 2 swelling or mild or moderate swelling with VA of 2100, is this papilledema? No. But if you see grade 5 or severe disc swelling with decreased vision, this is likely to be fulminant pseudo-papilledema. Okay, we mentioned earlier that sixth nerve palsy can happen in patients with increased intracranial pressure. We call it false localizing sign. So the sixth nerve is vulnerable to injury secondary to high intracranial pressure because of its course. So it exits the brain stem at the level of the pontomedullary junction over the clivus and then bend. It kink here in this area in the Dorillus canal under the pituoclinoid ligament. And in this area is very sensitive to any increase in the intracranial pressure. So that's why patients with high ICP can have sixth nerve palsy. It's not because of the length of the course, it's because of its special course. Fresnel grading. It's good to grade the optic disc swelling when you examine the patient. Grade 0 is there is no optic disc swelling. Grade 1, there is nasal blurred margin with temporal sparing. Temporal is clear, but the nasal is blurred. Okay. Grade 2, 360-degree blurred margins. Grade 3, there is obscuration of one of the major blood vessels. As you can see here, it's one of them is. You can see it clearly here is obscured. For grade 4, one of the major blood vessels inside the disc is obscured. Grade 5, all the major blood vessels on the disc are obscured. Okay? Fulminant IIH can be found in grade 4 and 5. Don't say fulminant if it's grade 2. This is something else. Tamam? Chronic, if it is chronic, then the disc swelling will decrease. You might see pseudodrosens, we call it refractile bodies, and eventually the patient can have pale gliotic disc. طيب, how to monitor the high intracranial pressure if the disc is pale? If the disc is not pale, then you can monitor the response to the treatment by doing OCT, measure the RNFL thickness, to see if it is increasing, decreasing. But if it's pale gliotic disc, how to monitor the high ICP? Visual field, excellent. What else? Patient's symptom? Yes, correct. What else? Difficult. With the pale gliotic disc, it's difficult. But yes, I don't depend mainly on SVB because sometimes it can be present and after 1 minute it's absent. Depends on the patient if they are holding their breath or. You get my point? I don't depend on it. What else? The OCT ganglion cell layer. Okay? The ganglion cell layer is underutilized. It reflects the subjective visual field testing that is done by the patient. For example, if the patient is having superior visual field defect, you can see it on the ganglion cell analysis as ganglion cell loss inferiorly. So you can monitor the patient by doing serial OCT ganglion cell layer. Visual field, we said earlier, enlarged blind spots, but if it's untreated, patient can have nasal step, arcuate, or constricted visual field, like in glaucoma. OCT of the RNFL, you need to do it in every visit to monitor the response to treatment and at baseline. And macula, of course, to see if there is any subretinal fluid. Then check for the blood pressure. Severe hypertension can cause bilateral disc swelling. However, be careful that patients with space-occupying lesion can have coincidental finding of hypertension secondary to the Cushing reflex, hypertension, bradycardia, and irregular breathing. So in patients with papilledema, you check the pressure, it's 20 over 100. Don't send the patient to internal medicine saying this is hypertension emergency, treat the hypertension, the papilledema or the disc swelling secondary to hypertension. No, you need to investigate. This could be brain tumor. Tamam? Temperature for infectious optic neuritis or meningitis causing high intracranial pressure. Height and weight and BMI. I think you all know why we check the height, weight, and BMI, right? صح؟ لأنه عشان IIH is associated with obesity. طيب. Before discussing the etiology, pathophysiology, let's just understand the physiology of the CSF. تمام? طبعا the CSF is secreted by the choroid plexus at the lateral ventricles. It goes to the third and then fourth ventricle. طيب. Then it goes to the subarachnoid space. طيب. And then It goes around the retrobulbar part of the optic nerve. احنا قلنا retrobulbar part has the CSF as well. صح؟ تمام؟ You all agree? طيب. And then it's absorbed by the arachnoid villi في venous sinuses. After that, it goes from the superior sagittal, transverse sigmoid, and to the venous circulation, internal jugular vein. Any problem, increase in the production or decrease in the absorption, will lead to high ICP and then papilledema. And you can name it. If there is space occupying lesion blocking this circulation, can cause papilledema. If there is dural venous thrombosis obstructing the venous outflow, and then the CSF will accumulate here, will cause high ICP. Any meningeal disease from infectious meningitis or carcinomatous meningitis can cause high ICP and papilledema. Clear? طيب الآن when you understand now the physiology and pathophysiology, what are you gonna do for our patients, the one with papilledema? عملتوا blood pressure, temperature, BMI, كل شيء. الآن what's the next step? LP? No. LP can be fatal ترى. تمام؟ ترى ما أدري مين قال LP بس أنا كنت سمعتها. ف LP can be fatal. Imaging, what imaging? MRI بس؟ لا دقيقة. MRI what? With contrast. Exactly. MRI, brain and orbit with contrast. Don't do MRI without contrast. Waste of resources. طيب. MRI, brain and orbit with contrast, looking for hydrocephalus, brain tumor. تمام. And then, what else? بعد MRI, brain and orbit. MRV. Somebody said MRV in the beginning, so we need to do MRV. ليش? To rule out venous sinus thrombosis. All right? Then after, if the MRV normal, يعني no space occupying lesion, إيش حنعمل? LP. طيب LP should be done in the lateral decubitus position, and some, if it's difficult or cannot be done, it can be done in prone position. Don't depend on the LP, the opening pressure. If the LP was done in a sitting position, it can be falsely high. طيب, it has to be in the lateral decubitus position. You ask يعني the one who will do the LP to send for the protein, glucose, cell count, and if you're suspecting malignancy, for malignant cells or cytology. تمام? You all understand why we order these. To rule out mainly meningitis or carcinomatous meningitis. تمام? Meningeal disease. And then ask for opening pressure. The normal opening pressure is less than 25 centimeters of water in adult, and in pediatric less than 28. Please make sure it's done in the lateral decubitus position or prone position. If it's done in the sitting, don't depend on the opening pressure. طبعا if the MRI show brain tumor, it's contraindicated to do LP. ليش؟ لأنه might have herniation. صحيح. Let's summarize the etiology of papilledema, brain tumor, hydrocephalus, venous sinus thrombosis, from any cause like coagulopathy, inflammatory, infectious, or malignancy. You need to refer to the specialized center or subspecialty like neurology, hematology, to investigate for the cause of dural venous sinus thrombosis. If there is extracranial venous outflow obstructing the venous system, طيب فبيصير في backflow وحيصير في يعني decreased absorption of the CSF, and then papilledema. Meningitis لأنه it's in the subarachnoid space. طيب. Infectious, carcinomatous, sarcoid. Secondary IIH from medication like isotretinoin, tetracycline, etc. Renal failure, severe anemia or endocrine disease. And if everything is negative, history, exam, imaging, LP negative, then you can call it primary idiopathic intracranial hypertension, which is the most common cause of papilledema. How you diagnose idiopathic intracranial hypertension or pseudotumor cerebri or benign intracranial hypertension based on the modified Dandy's criteria. You need to have symptoms of increased ICP, and we already discussed it in the history. Signs of high ICP like papilledema or sixth nerve palsy. No evidence of space-occupying lesion or venous sinus thrombosis on imaging, and the documented elevated ICP by the LP with normal CSF composition. If all these things met, then you can say it's IIH or idiopathic intracranial hypertension. السؤال الآن, is the MRI normal in patients with IIH? No, صح, تمام. ما طحته في الفخ, كويس. طبعا IIH typically affecting young, middle-aged, overweight women. The MRI is not totally normal in patients with IIH. You can see some signs like the empty sella syndrome or empty sella. This is the normal sella turcica. It's the location of the pituitary gland. Normally it looks like this. The sella is filled with the pituitary gland, but in patients with increased intracranial pressure or IIH, they can have this appearance of empty sella. This is not characteristic finding. This is characteristic finding, but this is not specific for IIH. It can be found in normal population. In around 35% of normal population, you can see empty sella. But again, this is empty sella and low-lying cerebellar tonsil. This is the foramen magnum. Normally, the cerebellum is above the foramen magnum, but if it is touching or below it, then we can say low-lying cerebellar tonsil. Vertical tortuosity of the optic nerve, as you see, I can see in this example. Again, empty sella. Posterior flattening of the sclera and distension of the optic nerve sheath. It's full of CSF. Make sense? عارفين ليش يصير الضغط مرتفع فحيضغط على البيتويتري فحتنضغط على تحت. البوستيريور سكليرا نفس الشيء، الضغط مرتفع فيضغط على البوستيريور سكليرا فيصير فيه flattening. السي هنا موجود السباركنويد سبيس full of CSF. فميك sense صح؟ كل هذول الساينز make sense with high intracranial pressure. What else؟ في MRV. This is the normal MRV, sagittal sinus, transverse, and then sigmoid. طيب. Normally, it's clear here there is no stenosis. بينما في IIH, you can see distal transverse sinus stenosis at the junction of the transverse sinus and the sigmoid. Here, it's bilateral. Again, the stenosis here. Everyone appreciate the stenosis? This is not venous sinus thrombosis, but it's stenosis of the transverse sigmoid junction. While here, there is no stenosis. طيب, how would you manage papilledema? Is there a cure for IIH? قبلا, is there a cure ولا لا? Yes or no? Yes. How? Weight loss. صح. Weight loss. أول شيء treat the underlying cause. If it's venous sinus thrombosis, you can send to hematology, neurology to treat this venous sinus thrombosis, to look for the cause and treat with anticoagulant, in addition to the medication that we will mention. If there is tumor, send to neurosurgery to treat that tumor. If it is meningitis, send to neurology to treat that meningitis. If it is IIH, weight loss is the only permanent cure for IIH. You need 6%. It's been shown in studies that 6% decrease in the weight can lead to resolution of disc swelling. Medication include acetazolamide or Diamox, which is carbonic anhydrase inhibitor. The dose ranges from 1 to 4 grams. Don't give 250 BID and that's it. No, it needs to be at least 1 gram per day. Up to 4 grams, okay? It's contraindicated in renal, liver failure, and pregnancy. It's category C in pregnancy. Side effects, the most common side effect is numbness, tingling sensation in the hand and feet, okay? Fatigue, depression. If the dose is high, you have to monitor the electrolyte for metabolic acidosis or hypokalemia. Topiramate or Topamax is contraindicated in pregnancy. It's category D, which is worse than the acetazolamide, can lead to oral clefts in infants. As you all know, that topiramate can cause secondary angle closure glaucoma due to choroidal effusion. The dose ranges around 100 milligram or 50 milligram BID. Common side effects include brain fogging. What if the patient is not tolerating the medication or the papilledema is still there, worsening with progressive visual loss? What is the next step? Optic nerve sheath fenestration. Excellent. طيب. It's indicated if the vision is threatened despite maximum tolerated medical therapy. And you need to send the patient to someone who can do the optic nerve fenestration because it's a risky procedure. They can damage the optic nerve, ischemic injury from CREO, double vision, or anisocoria. Double vision and anisocoria is fine. You can send to our pediatric ophthalmology consultant to do strabismus surgery, but CREO and optic nerve damage is serious complication. طيب, what if you don't have somebody who can do the optic nerve sheath fenestration? Or the problem is not the vision worsening, it's the headache. What's the next step? Shunt procedure, neurosurgical shunt procedure, either VP or ventricular peritoneal shunt or lumboperitoneal shunt. It's indicated if the vision is threatened or headache despite maximum tolerated medical therapy. Complications include infection, bleeding, infection either in the meningitis, peritonitis, hemorrhages, or over drainage. What else? What procedure you know? endovascular stenting. احنا قلنا في stenosis في الترانسفيرس sigmoid junction. Some neurosurgeon can do stenting at that area to dilate this stenosis with, and this has been shown to improve papilledema and idiopathic intracranial hypertension. What else? ممتاز. bariatric surgery. طيب. clear papilledema. IIH clear. في any question? Let's move forward. 17-year-old woman complaining of vision loss over 3 days plus pain with eye movement. Vision LP right eye 2100, left eye, color vision 0 out of 11. Sluggish reaction of the pupil. Motility full dilated fundus exam is shown here. Diagnosis. Atypical. Bilateral atypical optic neuritis. This is not papilledema, okay? في أحد يعترض إنها papilledema؟ أول شيء الكورس is over 3 days. Pain with eye movement. Severe vision loss. طيب. And the disc swelling is grade 3. It's not grade 4 or 5. We can say it's fulminant. طبعا MRI orbit. هذه ميزة الأوربت. لو عملت MRI brain عادية it will not be shown here. If you do MRI orbit with fat suppression with contrast, you will see this finding. You can see the contrast enhancement here of the optic nerve sheath. Normally, the optic nerve should not enhance. طيب. The color of the optic nerve and the sheath should be the same color as the brain. But if it's enhancing like the muscle, we say it's optic nerve enhancement. It's bilateral. تمام. So we can say it's bilateral optic neuritis / perineuritis. طيب. It turned out to be MOG-associated optic neuritis. طبعا هذه beyond the scope of the lecture. I'm sure it should be discussed in optic neuritis, but you need to understand to have broad differential whenever you see a disc swelling. طيب. 19-year-old woman complaining of intermittent episode of vision loss lasting for minutes. It's not seconds. طيب. احنا قلنا TVO of papilledema is seconds, but this one is minutes. Right eye وهذه left eye. Vision 20/20, color vision is normal, pupil normal, motility is full. Diagnosis. طيب الرايت اي نورمال كلكم تتفقون. طيب الليفت اي في ديسك سويلينج. طيب what else? CRVO, excellent. This is CRVO. All right, that's what you need to do for dilated fundus exam. Don't just examine the optic nerve. Oh, there is swelling, call neuro-ophthalmology or do MRI, send to neurology, other hospital. تمام. فyou need to do dilated fundus exam, check. طبعا بالدايليشن كان في hemorrhages here موجودة في البريفري. هنا ما هي واضحة مرة. Here 47-year-old. طبعا كل information بالhistory is very important. Age of the patient, gender. تمام. 47-year-old woman presented with sudden drop of vision in the right eye. Sudden. تمام. Past medical history, diabetes, hypertension, obstructive sleep apnea. Vision 20/40, right eye 20/20 left eye, color vision is normal, pupil relative afferent pupillary defect in the right eye, motility is full, and this is the visual field defect. Okay, we can say it's طيب okay NAION or ischemic optic neuropathy تمام anterior ischemic optic neuropathy. Why? It's sudden طيب وفي RABD وريسك فاكتورز older patient طيب what else visual field defect is typical of NAION which is superior arc weight or altitudinal defect and the other eye small crowded disc. This is the full picture, the typical picture of NAION. طبعا this patient مو في كيكش في other hospital treated as a case of papilledema. Clear? ولا في السعودية برا. طيب 13-year-old boy medically free came for regular eye check no complaint. VA 20/20 color vision normal pupil normal motility full. Diagnosis طبعا هذه ايش؟ drusen superficial disc drusens or pseudo disc swelling pseudo-papilledema. clear واضحة بس المشكلة مو في السوبرفيشال drusen المشكلة في البريد drusens. What are the characteristic findings in pseudo disc swelling? Typically normal visual function, no symptoms, asymptomatic, no obscuration of the blood vessels. You can see anomalous branching of the vessels here. Absent cup. احنا قلنا في true disc swelling there is retained cup. No peripapillary hemorrhages, no exudates, no cotton wall spots. Those are examples of pseudo-papilledema. Here small crowded disc, tilted nerve, and superficial drusens. What is this? Double ring sign. Optic disc hypoplasia, exactly. This one, small crowded disc, and this one, tilted disc, anomalous branching with, and this one, clear, ممتاز. What about this one? Buried drusens, تمام, by the B scan finding. طيب. Can anyone describe here what's going on? A and B. Totally different diagnosis. طيب A, what do you notice here? Tortuosity, there is blurred nasal margin. And the same thing here, blurred nasal margin. Is this pseudo or true? Is this pseudo or true? ليش true? Which one is true? Which one is pseudo? A is true and B is pseudo, صح؟ أنا ما أعرف. I don't know. The first one turned out to be pseudo and the second one is true. Sometimes we cannot differentiate by just looking at the optic nerve. You need to have full history and examination again. If you cannot differentiate, you need to do ancillary testing. All right? طبعا شكلها هذه true هذه شكلها pseudo صح؟ لأن شكلها more severe. But sometimes you cannot differentiate. There is no clear signs of true like hemorrhages, exudates, cotton wall spots, obscuration of the blood vessels. تمام؟ طيب how to differentiate? You can do autofluorescence. And you can see the drusens in the autofluorescence here. طيب. You can do B-scan, which can show the hyperdense calcific material here. طيب. You can do OCT, which can show the hyporeflective core with hyperreflective margins. Drusen can be shown in the enhanced depth OCT, okay? Like the Heidelberg. CT scan can show the calcific drusens. ترى كل هذه الحالات real patients seen in the clinic. طيب, if you cannot differentiate, you can do FFA. What is the characteristic finding in true disc swelling? Leakage. بينما في السودو staining. ممتاز. If you cannot differentiate, you can do MRI. it's safe to do MRI to make sure there's no space occupying lesion. طيب. If you're still لسه you don't know, you can go ahead and do LP finally يعني to measure the opening pressure. Which one is pseudo, which one is true? The first one is true, there is leakage here. And the second one is pseudo, no leakage, there is staining. طيب, what's optic disc drusen? Those are hyaline-like calcific nodules made of mucoproteins and mucopolysaccharides. In 70% of the cases, it's bilateral. It's not totally benign condition. It can lead to complications like visual field defect. The most common visual field is the inferonasal visual field defect. Patients can have enlarged blind spots or constricted visual field. It can cause or can predispose to choroidal neovascular membrane, NAION, and central retinal artery occlusion. You agree, Dr. Tariq? Okay, good. طيب, no. طبعا هذه الحالة, what do you think? طيب, are you sure it's true? طيب, if you are not sure, قل true versus pseudo. Don't confuse the neurologist. لما تقول there is disc swelling or grade 1 or grade 2 disc swelling in neurology, خلاص, they will think it's true. They will do aggressive investigation. You can just mention in your impression pseudo versus true. Clear? If you're not sure, ما هي زي الحالة الأولى اللي واضحة true disc swelling. طيب هذا البيشنت عملنا له الانسيلاري تيستينج, no evidence of drusens, autofluorescence, OCT, normal MRI. طبعا it's suspicious. We did, طبعا they did, it's not my case. They did MRI, MRV, normal. They did LP with normal opening pressure. They follow up the patient, normal appearance over time. So this is pseudo disc swelling without drusen. Any question? طيب, thank you. يعطيكم العافية. إذا في أي سؤال تفضلوا. طبعا I would recommend those references, the case-based neuro-ophthalmology. This is an online free reference. It's excellent resource, cases, question and answer, and this book for neuro-ophthalmology. طيب. And again, this is your favorite American Academy of Ophthalmology. But this resource is very short, informative. Okay. Yes, تفضل. For which case? Dry. It's we mentioned dry for the macula, if there is macular edema or not. But the OCT, I mean, negative for drusens. But there is elevation of the optic nerve. هذا قصدي. No evidence of drusens in the B scan, autofluorescence, and OCT. هذا قصدي. تمام. Yes. And there are symptoms, right?
But you need to go further to do investigation, right?
طيب, حلو, good, excellent. طيب, which one is more serious? Grade 1 or grade 5? It doesn't matter. طيب, patient with brain tumor can present with grade 1, or patient with IIH can present with grade 4 or 5. تمام? Let's agree on this. حلو? You said grade 1, you think, oh, there is symptoms of high intracranial pressure, headache, or TVO, you send for imaging. طيب, and you do مثلا a B scan or no drusens, then you can send for imaging. Yes. When to treat?
Imaging before, and no need to go for OCT or like this thing.
If you are in the clinic, you have access to the ancillary testing. If you are in the ER, it depends on the situation, where you work, what resources you have. If you don't have the resources, I think it's good to do the imaging. Yes. طيب. You mean like from optic neuritis, or? You can use it. You can use it. Yeah, that's fine. But in the impression, you have to mention what's your impression, what's going on. دكتور عبد الله تفضل.
Thank you, Dr. Ahmed. Very nice lecture. I have a question regarding papilledema, and sometimes also we see with hyperop patients, you can see the disc is slightly
Yes.
swollen. So,
Yeah.
is there a way that you can tell is this swelling or this is just hyperopic disc?
Excellent question. It's sometimes difficult. We can do OCT to check for the elevation, the RNFL elevation, to check the symptoms of the patient. All right. If the patient is totally asymptomatic, hyperopia, you do the OCT, there is no thickening of the RNFL. You can check the Brooks membrane if it is going up or down. If it is going down, this means it's unlikely to be from high intracranial pressure. If it's going up, then you suspect high intracranial pressure. It's good if you're still suspicious to go for imaging. If the imaging is negative, I don't think there is need to go for aggressive investigation like LP or other, invasive procedures. You can follow up the patient, make sure there is no worsening. If you can do the OCT, it's good, or you can do a serial dilated fundus exam to make sure it's stable.
And how accurate is the OCT? Because sometimes we do OCT and you see over the disc, there is like, you can see there is elevation, but still, is this elevation?
Yeah, you can check the total RNFL thickness.
The thickness of RNFL?
The thickness, yes. Normally it's from 80 to 100. يعني if it is مثلا 200, 200, no, there is something. Okay? Sure. But if it is 110, it's in the gray zone.
I see. Thank you.
That's why we need to do the OCT. You mean asymmetric? Yes. It can be asymmetric. Unilateral IIH is very, very, very rare. If it يعني خاصة الحالات اللي قالوا unilateral, the other eye has something, grade 1 swelling, and the other one is grade 4. It can be asymmetric, yes. طيب يعطيكم العافية.